All right, everyone, if you're joining us live here, we're going to give it like 30 seconds to let everyone get in here before we start things. Thanks for your patience. All right, looks like we've plateaued, so that's usually my cue to kick things off. Hello, everyone, and welcome to our 23rd episode of Ewing's You. For those of you that don't know me, I'm Piero Spada, and I'll be your host today. I'm also co-founder at Little Warrior Foundation, and more importantly, father to now 14-year-old little warrior Lucy. If you're part of our core contingency, aka the Little Warrior Fight Club, thanks for being here with us since day one and making this a place for positive change. And if you're new, well, welcome to Ewing's You. It's our webinar series where we hear from leading sarcoma experts and discuss the cutting edge of care and science behind Ewing sarcoma. Today, we'll be hearing from one prominent expert in Dr. Rashmi Chugh to discuss a relatively new clinical trial for relapsed and refractory Ewing sarcoma in INBRX-109. Briefly, Dr. Chugh is a medical oncologist at the University of Michigan Rogel Comprehensive Cancer Center, specializing in the care of patients with sarcoma and connective tissue tumors. Her research focus is in the development of new therapies for patients with sarcoma. She serves as the co-director of the Connective Tissue Research Team, co-medical director of the Michigan AYA Oncology Program, Associate Division Chief of Clinical Services for the Division of HemOnc, and is a member of the Scientific Steering Committee for the Sarcoma Alliance for Research through Collaboration. She received her medical degree at WashU in St. Louis, followed by her internal medicine and HemOnc training at the University of Michigan. Also, I want to give a shout out to INBRX for creating and sponsoring this trial and for helping us coordinate this Ewing's You episode today. But before we kick things off with Dr. Chugh, just a quick reminder that Ewing's You is a webinar production of the Little Warrior Foundation. We are a national childhood cancer foundation with a laser focus on finding a complete and permanent cure for Ewing sarcoma. We were founded in April of 2020 and have now granted out over $2 million in high potential therapies for increasing survivorship and decreasing toxicity. And in order for us at Little Warrior Foundation to make programs like this a reality, we rely on the support of the little and big warrior community alike. We appreciate all of your support so we can continue our mission of bulldozing our way towards more effective and less toxic therapies and continue this vital work for kids battling Ewing sarcoma. Just one housekeeping item, please, by all means, as Dr. Chugh presents, enter your questions into the Q&A box in the lower right-hand corner of your screen, but please be reminded we cannot discuss patient-specific matters. This is not the time or place, but by all means, enter your general questions into the Q&A box, and we'll do our best to answer all those questions at the tail end of this presentation. And then last but not least, on our end, unfortunately, Emily couldn't be here to join us today, but in her stead, I am excited to introduce our Director of Operations, Alana. For those of you that don't know Alana, she does the heavy day-to-day lifting at Little Warrior Foundation, and anything fundraising and events related, she leads the charge there. So Alana, welcome to Ewing's You. If you want to say hi quickly, we'll get things kicked off then.
Hi, everybody. Excited to be here with you today, moonlighting as Piero's co-host. Very excited to be here and help moderate with our Q&As. With that, I'll kick it off to Dr. Chugh.
Wonderful. Thank you so much for that kind introduction. And such a privilege to be here to talk to you guys about something that I know you guys are passionate about, but I also am passionate about from another direction, which is really advancing the care of patients with Ewing sarcoma. And so happy that INBRX was kind enough to give me the opportunity to speak on behalf of them and their co-investigators on this study, which is a phase 1 trial of ozekibart, otherwise known as INBRX-109 in Ewing sarcoma. So I know you guys, and just the disclaimer that this product is still investigational and still under study. So I know this audience is very familiar with Ewing sarcoma, but of course cannot start without the obligatory kind of this is a problem, right? So Ewing sarcoma is a rare aggressive tumor that we see in both kids and adults. Full disclosure, I'm a medical oncologist. So I know a lot of folks you meet are pediatric oncologists that do a lot of research, but there's a fair number of us in the adult side that care a lot about these patients and this disease. So we know it's most common in adolescence and young adulthood. And there's about 250 cases a year in childhood in the US. But I wanted to kind of even just to speak to impact. There's many adults with this disease as well, and it doesn't get captured in the same way as with kids. There's a lot of young kids that relapse later in life that, usually these numbers that we quote are what we call incidents, like how many cases, occur at one given time newly diagnosed, but it doesn't take into account the lifelong impact and the relapses of patients later in life and that get these later in life. So this, although, people often think about this as a rare disease, it's more common than you think. It's a bigger problem, and obviously it impacts very important people. So, and as you all know, the prognosis in patients with metastatic Ewing's is poor, and relapse is is much more common than we'd like. While we have great vetted treatments in the first line setting, they are not perfect. And in the relapse settings, there's not as many effective treatments. So, roughly we know the cure rate for localized disease is in the 60 to 75% range. So really, excited that the majority of patients with localized disease are cured, but that number is much lower for patients with metastatic disease and even lower for patients with relapse disease. And so to that point, our treatment options are limited in this setting. And, when relapse occurs, we always recommend patients should be referred to a sarcoma center and receive care by a multidisciplinary team that have expertise in bone sarcomas. So our data in the relapse setting, I think is important to kind of set the tone as we go into this discussion. A lot of it, the most objective data is based on this study called the RECUR study. And this was an international randomized study that was done in Europe, which took patients that had newly relapsed, so second line, had already been through the first line treatment, which I think you all might know that might be a little bit of some differences between how we treat in the first line in the United States as opposed to Europe. But in Europe, there can be very well organized. And so to help us understand what's the best treatment when the disease ends up coming back or not responding to first line treatment, they organized this randomized study to kind of take the most commonly used regimens that we use standardly in the relapse setting to just kind of quantitate, well, gosh, can we figure out which is the best one to give for our patients? What is the best way to approach, patients when the disease comes back? So they did this kind of complicated randomization, which just means they randomly assigned patients that were eligible to one of 4 different treatments. One of them is called topotecan and cyclophosphamide. One of them is Irinotecan and Temozolomide, and we're going to pay special attention to this because this is kind of the backbone to this study we're going to be talking about. The next one was gemcitabine and docetaxel, and the other one was high-dose ifosfamide. So with this study design, patients were randomly assigned to one of 4 of these treatments, and then they looked to see how patients did. And they took the arm that did the worst, to be honest with you, and they said, okay, we're not going to do that arm. And then at a next assessment, they dropped another arm, and then so on and so forth until they did kind of a more comparison to 2 arms. So the point in all this is I wanted to let you know this was our first really largest study to kind of quantitate how well does this combination that we use very frequently in the relapse setting, irinotecan and temozolomide, how well does this do with patients with relapse Ewing sarcoma? And based on how this arm did, we learned that the response rate and so tumor shrinkage rate was about 20%. And then the median progression-free survival was 4.7 months. So that just means, gosh, on average, how long it took before patients' disease became uncontrolled again. So it controlled it for roughly about 4.5 months. But always remember that there's some patients that do a lot better and some patients that don't do as well, but that kind of when we took the average. So this is one of our most commonly used regimens that, that's one of our go-to regimens. So obviously kind of looking at this, we hope that we could do better. So to summarize, irinotecan and temozolomide is frequently used, but the response rate was relatively low in this very well-conducted study. In some of the other studies that have been conducted, there are some studies that show, gosh, there might be a higher response rates in some setting, but, we usually kind of look at studies that are what we call prospective. So do a study of patients and see how they do, rather than do a study and look back and see how patients do, which is called retrospective. We know that the other standard treatment options in that study, the recurse study for relapse or metastatic disease, have some activity, but they were still left something to be desired. We had some more responses, but the event-free survivals, so similar, like how long the disease was controlled before it started to grow, was a little bit higher in ifosfamide, similar in Cytoxan and topotecan. So of all the drugs we have for the immediate relapse, gosh, we're hoping we can do better. And so based on that, we always, as sarcoma physicians, we recommend enrollment in clinical trials just to see if we can do better. And that's in part of every one of our national guidelines, just because we don't have as many treatments as we'd like in the relapse or metastatic setting. So with that, I'm going to talk to you about this drug ozekibart. So this is a drug that had a lot of interest kind of in the laboratory and then clinically in patients with Ewing sarcoma. So let's talk about what this drug is. So this is kind of what we call a novel or next generation kind of exciting new treatment that the way that it works is forgive me if I get technical on you, it's a tetravalent DR5 agonist, and it uses an antibody platform. So we know in Ewing's, we have a lot of chemotherapy that kind of, but we don't have a lot of targeted treatments, really targeting different important pathways like we do in some other diseases. But this one is a targeted treatment, and the way ozekibart works is basically it has these different areas. This is a picture of the compound that binds specific receptors on the cell, and it activates this DR5 pathway, and it induces what we call programmed cancer cell death. But another way of putting it is it basically kind of convinces a Ewing cell or a cancer cell to kind of undergo suicide and kind of die in and of itself. So the drug itself is a little bit unique. There's other drugs that have targeted this pathway before, but they've designed it in a way where it has 4 different domains that can basically help engage this pathway a little bit more effectively. They designed it in a way that some of the components that can get in the way were removed, and in a way that would allow better penetration. So this pathway, to give a little more detail, DR5 is this Q receptor for this is apoptosis, just means that cell death I talked to you about. So so it's really important in this pathway of kind of the cell kind of dying off itself. And this pathway is also, more globally known as trail. Basically, so this trail pathway induces this cell death through interacting with this DR5, which is kind of depicted. So I want you to imagine this is the cell surface. And we see this protein on the surface of cells that are damaged, and that's one way we get rid of cells that aren't working as well. But it's also very active on tumor cells and not very active on normal cells. So particularly on Ewing cells. So this is why it was a good target here. And what this drug does is it basically comes together and it clusters multiple of these receptors at the cell surface in order to kind of synergize these cell death signals to induce cell death on the for tumor cells that have this expressed. So this is kind of a more visual, so where basically we have this INBRX-109 drug coming in, and what it does is it clusters up these DR5 molecules that are on the surface of tumor cells, and by binding it together, it causes this complex that we call the death-inducing signal complex. I know that sounds foreboding, but that's what we want with Ewing's. We want to induce death. And that this ultimately results in programmed cell death. So we know that just, a lot of times we need something to help these drugs, targeted drugs, work. And the INBRX and some other team members did some elegant work to give some rationale where how can we combine this, induce some damage to these tumor cells so that INBRX-109 or ozekibart can come in and help induce some of the cell death. And you can see, again, these are a little bit complicated, but I'm going to focus on this one. So, and these are from preclinical studies that showed, well, gosh, when we at a different time after we look at treatment with various venues and we look at the tumor volume, when we didn't treat the tumors with anything, the tumor volume was high. When we treat it with just the ozekibart or INBRX-109, it was kind of variable, similar with irinotecan. But when we did it and combined those two strategies, the targeted and the chemo, we induced the damage from the chemo and then kind of helped complete the cell death with INBRX-109. There was a nice benefit. And again, this is in the laboratory. Now we're going to talk about what happens when we treat patients, which is most important. So as part of a larger phase 1 study, ozekibart was combined with irinotecan and temozolomide with a special cohort of patients with Ewing sarcoma. So the study started out as kind of a first safety lead-in. So this is kind of the name of the cohort because there was multiple groups of patients on this study. But the first Ewing's cohort was taking patients initially with a lower dose of the ozekibart, and then if that seems safe, then go to the higher dose. And then they essentially combined it with what we consider pretty standard dosing of temozolomide and irinotecan, which again is one of our standard relapse regimens. Then there was a second safety lead-ins that they wanted to absolutely make sure that there was good safety by starting with kind of the dose that we've determined is important with ozekibart. And we'll have some data about these two cohorts. And then based on that, based on some promising data, the team is enrolling to this expansion cohort, which is kind of a common way when we see good signals in an early phase study. We expand the study to see if we can see more activity of a compound when we treat more patients. So again, first we look at safety and get a preliminary idea of how well it's working. And then we're expanding it and trying to see how 50 patients with Ewing sarcoma treated in the second line setting does. So this is this study part that's currently enrolling. And it's currently enrolling patients that are 12 and older. And remember, there's still some safety data. So even though we want to be as inclusive as possible, we have to, be careful and smart with how we do it. And right now we're looking at patients that have received at least the first line treatment, but no more than 2 prior treatments. So I'm going to go over, this is some of the initial data that from the first 2 cohorts, the safety data from 14 patients that had received ozekibart. And the initial, when they were still trying to look at this safety, they included patients with both Ewing sarcoma and other what we call Ewing's like tumors or other round cell sarcomas. They're not necessarily Ewing sarcoma because there's a very specific definition based on the molecular genetics of Ewing sarcoma, but a lot of times we treat patients with round cell sarcoma similarly. So we're able to kind of use that data. So this is just gives you just some general information. I won't bore you with all the details, but this is important to just know, in this initial part was only including adults because that's kind of how we initially establish safety a lot of times. And there was quite an age range from 20 to 70. And then there was slightly more men than women. And almost all the patients had metastatic disease, but also patients that had locally advanced disease that couldn't be cured were included. And then there's some different types of, we looked at the different gene fusions, which is important for Ewing's and other diseases, just to have that information so we can learn from that. And we know that a number of patients had already had prior irinotecan and temozolomide, as well as a number of other regimens as well. In terms of the side effects, a lot of the side effects were similar to what you might see with irinotecan and temozolomide. And that includes things like diarrhea. Nausea was another one, as well as fatigue. And these are things, like I said, that we see with irinotecan and temozolomide. We also know that there are some overlapping side effects with the ozekibart can also cause some diarrhea, nausea, fatigue, but in general, it's pretty well tolerated and didn't seem to be that much more challenging than tolerance to irinotecan and temozolomide from my perspective. So this is, again, I won't go through the details. It just kind of goes through how frequently anybody had side effects. And then, and a lot of these were mild. The ones that were kind of more severe really were the diarrhea in about 35% and some nausea and low blood counts, which we're all used to dealing with Ewing's treatments. So this is getting a little bit about how well did this work. And what this is a type of plot where we can look at, we take the baseline tumor size that we're looking at in our patients, and then we look, well, gosh, what's the best amount of shrinkage that we saw when we compare the baseline tumor size to kind of the best shrinkage we received. And so this is kind of where everybody starts at baseline. And if you go below the line, that shows how many patients had tumor shrinkage and to what extent. And then this is, if you go above the line, that means kind of our best response was actually growth, and we didn't have as much benefit as we'd like. So you can see here that most people are below the line. And gosh, sometimes we had people that had really significant tumor shrinkage that we were pretty excited about. So in general, most patients had reduction in tumor size from baseline. And they were observed both in the green is patients with our classic Ewing's, and then the this kind of blue-gray is patients with other round cell sarcomas. Of the patients that had tumor shrinkage, most of them had the dose that we're moving forward in this study, which is at 3 milligrams per kilogram with our standard dosing of temozolomide and irinotecan. So if you could tell from this, if you remember when I started talking about in the second line study, our best study of irinotecan and temozolomide, in the recur study showed about a 20% shrinkage rate. And here, even though this is really, we're just talking about a small group of patients, we're already seeing, gosh, a really promising tumor shrinkage rate that have gotten us excited about this compound. The other thing that's exciting is that we've had some people that have been on treatment controlling it for many, many months. So we talked about also that, sometimes we have really, short, amount of benefit from some of the drugs that we use. So far, with this is another type of plot that really looks, gosh, how long a patient is on this study. And it also tells us kind of whether they had a partial response, which means if its tumor shrinkage is at least 30%, or whether it's stable disease, which is that it's not shrinking a lot, but it's not growing a lot. And you can see here that we've had some people with these really prolonged tumor shrinkage going out, close to a year. And again, some of these patients at the time this analysis was done, the arrow means that they're still, kind of ongoing on treatment. And then, of course, unfortunately, this treatment hasn't worked for everybody, but overall, based on the first group of patients we were treating, we saw a response rate of 54%. And again, that's compared to if we can never compare one study exactly to another unless it's under one umbrella. Just kind of, if you think about what we saw with the other studies, this is really favorable. And another important thing we look at is a disease control rate. So that means that we had some patients that had, even if they didn't have tumor shrinkage, it controlled the disease for a while. And the other thing that was exciting, we saw it both useful in Ewing sarcoma and other round cell sarcomas. And when they did this analysis, there was 4 patients that were still going strong on this study. So overall, some really promising data, making us excited to move forward. I'm going to talk to you about just a case study of one of the patients that was on the study. And this happened to be one of my patients. And this is a 31-year-old gentleman, and I'm even gonna backtrack. This amazing young man was actually diagnosed when he was 10 years old. Went through the standard treatment, did incredibly well, and then at the age of 17, it came back, and at different times, was able to control the disease. And kind of, when I met him, he had been through a lot of other treatments. And then we enrolled him on this clinical study of INBRX-109 plus irinotecan and temozolomide. And he had at some point in his course had irinotecan and temozolomide before. And I'm going to show you, these are 2 different lesions in the lung. This is TL1, tumor lesion 1 and tumor lesion 2. And I'm going to show you, this is how it looked at baseline, one of his spots, and this is another spot at baseline. And then after being on the treatment here for 42 weeks, you can see how this spot kind of went to this spot. Another one, this spot went to this spot. So really nice, dramatic tumor shrinkage at after 42 weeks, he had about a 60% decrease in the size of the spots that we were able to measure. And really, what was interesting with him is, it's hard to stay on the chemotherapy portion for that long a period of time. And after 29 weeks of treatment, there was a lot of flexibility with the protocol to make it patient-friendly. We knew the irinotecan was tough on him, so we were able to stop the irinotecan and continue treatment with INBRX-109 and temozolomide, which was really well tolerated for him, much better than the triple combination. And his at the time of this evaluation, that response was able to be sustained on just those 2 agents. So really, a remarkable young man, and really helps motivate me and hopefully others to kind of keep looking for new drugs that we can make an impact with. So right now, this study is ongoing. in patients with locally advanced or metastatic solid tumors, multiple different cohorts, but the one that we're going to focus on here is Ewing sarcoma. So in the second or third line, treated with irinotecan and temozolomide along with ozekibart. And so there's some additional information, if it's relevant to you or somebody you know, about the study on the clinicaltrials.gov website. And this is just a diagram of where the study's open in the United States. So the team at INBRX has done a great job at trying to kind of expand the footprint. We know that, you know, patients are located everywhere in the US and then even in Europe. And so these are all sites where that study is accessible. The hope is, you know, this is a rare tumor. Sometimes it's hard to catch people before they've had a lot of other treatments. And, you know, we're trying to focus on patients in the second or third line setting so we can figure out if this is going to be a good option moving forward, if we can add this to our kind of clinical trial treatment armamentarium is kind of how we put it. So to summarize, in this phase 1 study, ozekibart, along with irinotecan and temozolomide, showed some encouraging anti-tumor activity. And again, we're still working forward to you know, of course, we know that there's some good activity and we're never satisfied. So in people with Ewing sarcoma, we saw 5 partial responses. So it would be a response rate of about 70% and disease control in a patient, so a disease control rate of about 85% with a manageable safety profile. So this is kind of what supports this expansion profile, that's the expansion part that's still enrolling now. That age group has dropped to 12 years. So with that, that's what I wanted to share with you guys. And again, a privilege to speak with you and share an exciting new study, and would love to have any questions or comments.
Yeah, Dr. Chugh, that was fascinating. Thank you so much. Before the questions trickle in here, I do have a couple questions that hopefully can help tee us up here. Can you talk about the scheduling? Like, how often is the IT backbone administered, and what does ozekibart look like? Is it oral? Is it IV? And how often is that given? Can you comment on that?
Yeah, no, that's a great question. So it's the schedule of irinotecan. I'm going to see if I can reference. Essentially, this is similar to our fairly commonly used schedule that most physicians use. And this is a little bit debatable, to be honest with you. There are some other schedules of irinotecan and temodar, but the one that most folks use, the temodar is given 100 milligrams per meter squared on days 1 through 5, along with irinotecan 50 milligrams per meter squares on day 1 through 5, and that's a 21-day cycle. There are some alternative schedules, and some of those, you know, there can be some small studies that show variable level of benefits, but most patients, for convenience as well as, you know, the benefit and retrospective studies, use this schedule. Now, the ozekibart is just given on day 1. It's intravenously. And it's not too long of an infusion, doesn't add too much time to the day, and is only given on day 1 of each cycle.
Okay. And as long as you're seeing a response, does that schedule continue, or like when do you make a decision? Is it just based on tolerability and when some of the chemo falls off, or how do you make that decision?
Yeah, that's a great question. And I think that, you know, when we have disease that we don't know how to get rid of altogether, there's always the question, well, how long do we continue? And it's definitely a balance between benefit from treatment and, you know, quality of life and tolerability. The way the protocol is written, it gives some flexibility. You know, so after 6 cycles. So usually it's pretty standard, at least to shoot for 6 cycles of when we do a chemotherapy regimen. Sometimes we go much longer, you know, 10, 12, 14 cycles, but we at least try to do 6 cycles with a combination of all 3. And then I just basically, you know, talk to my patients about how they're tolerating things, how their quality of life is. And there are times where I've had people that have kept going with the triple combination. I have one that's rolling quite some ways out and feels like it's worth it, the side effects. And I have others that we've dropped you know, one irinotecan usually, or both irinotecan and temozolomide. And you can continue with the INBRX, the 109, basically, as long as we're still seeing enough, we're still seeing benefit.
Okay. And in terms of tolerability, it seems like most of what you guys observed in terms of adverse events was just like irinotecan, like diarrhea, seems to be the predominant one. Is that correct?
Yeah, I think the side effects of the chemotherapy really outshadow the side effects of this more targeted agent. You know, when we've dropped the chemotherapy portion, the quality of life goes way up, to be honest with you. So even though there's a low incidence of side effects when it's given alone, it's much more tolerable.
Okay, good to know. Alana, are there any questions there? Otherwise, I'll keep going.
We got a couple here. So if you don't mind, you touched on the importance of seeking out potential clinical trials. Are there any general words of advice that you would provide to a warrior and their family when selecting a clinical trial?
That's a great question. And I think, honestly, as someone that's been taking care of sarcoma patients for 20 years, that's even hard for me to navigate, you know, because when you're looking at a new treatment, you know, there's limited data. And even though we're excited about one treatment, gosh, we've had so many excitements that haven't panned out. And so it's hard to predict. I think that talking to your sarcoma specialists would be important, because there's a lot of information we share at meetings, we share as a community, because we all pretty much know each other, you know, and can, you know, try to do our best to help guide you. But I would say, you know, the most important thing is getting feedback for someone that's a bit expert in the field. And if they have something that they can go on, they'll share with you. But it's very possible that they may be, you know, hey, you know, I'm not sure these both seem reasonable options. And if there's more than one reasonable options, the things that I would look at is, well, gosh, is there any, if I do one, does it exclude me from the other, and vice versa? And then you want to have as many options as possible. So gosh, if this is only including patients that you know have only had one treatment, then I want to do that one first, because the other one will include if this one doesn't work, and I can try that later.
Thanks for that. Just a reminder to submit your questions in the Q&A box in the lower right-hand corner. I do have a question. Is there a reason that you're targeting fusion positive sarcoma with this? Does it have to do with the DR5 prevalence on the tumor cells? Can you speak to that? Because I noticed on the preclinical side of it, you touched on that loosely, but there were several fusion types that you were going after with this targeted approach.
Yeah, I think that most of the data is in Ewing sarcoma in general. I think there's definitely a signal in other sarcomas. And when we're designing a study, already we know that some Ewing sarcoma patients, you know, one treatment works better than the other. And when we end up having too many variables in a study, it ends up becoming confusing to interpret. So sometimes if we kind of focus on you know, fusion positive Ewing sarcoma, then we know it's kind of a pure group that we're looking at. And once we establish if there's benefit in that group, then there usually is kind of some room to see if we can extrapolate. So I don't think it's necessarily that that's the only group we think it'll help with. But, you know, first, in order to get kind of new drugs to our patients, we have to, you know, go through an approval process and prove that it'll work. And sometimes that purest population is the easiest way to do it.
Cool. And I noticed you listed EWSR1 times 2. What is that? I recognize the other subtypes, but the one other one, I don't want to call it out, but I was like, what is that?
Yeah, I think that there might have been 2 different fusions in that.
Okay.
So I'm not specific for certain, but we've seen that a few times. So I'm guessing that's what they meant by that there wasn't just
Okay.
one present.
All right, thanks.
I know that seems crazy. This is, you know, me and my colleagues often say it's the most complicated simple tumor, which is kind of driven by this one abnormal fusion. But It's
Okay,
tricky.
thanks. Yep. Alana?
Do you have any kind of timeline or insight on when this could potentially be brought to the under 12 patients? Just I understand the safety, point of what we're doing now, but just wondering if you have could speak to that timeline or thought at all.
Yeah, that's a great question. That, I'm honestly not sure. I think that the team from INBRX can answer better to that. Were able to get permission to go. The initial age group was 18 and up, and we're able to go down to 12. But a lot of times, until we have that full cohort of 50 patients enrolled, I'm guessing it might be difficult to drop that down. But I can't speak to the timeline for sure.
Okay, thank you.
I got a question. Is this systemic therapy like post local control, like post surgery or radiation with these relapse patients? Or how does that dovetail within like the schema that you kind of outlined?
Yeah, no, so this is for patients that have what we call measurable disease. So it's usually we don't do local control. We don't do it post local control because then it's hard to figure out if there's benefit. Sometimes it's always hard to incorporate systemic therapy with local treatments in patients with metastatic Ewing's, because sometimes it makes sense to remove or radiate each one of the spots, and sometimes it doesn't. So I think that we would usually use this in a setting where we think that systemic treatment makes the most sense at that moment in time. And if at any moment in time it makes sense to do local control, where we end up kind of dealing with the disease, the spots that we're following, then we would make an educated decision whether to come off of the treatment study and kind of go for that strategy.
Okay. And along those same lines, are you seeing this therapeutic approach more effective in certain tissue types? Like you kind of highlighted that case study where a super responder in lung. Are you noticing a difference between bony mets, lung, soft tissue, et cetera? Or is it still too early to tease out?
That's a great question. And that's kind of always a question. Well, especially in a targeted treatment, well, gosh, can we figure out how to enrich for the most benefit? And those studies I know are ongoing. They've been collecting a lot of, clinical data. But it is really like this cohort that I presented right now. I only presented that first 14 patients from that initial safety lead in, and then the run in. So that's, the ongoing study, we can't present the data. It's still ongoing, it's still enrolling.
Right.
We don't have it all teased out, but I bet you we're going to be able to do a good analysis and just see if we can find any hints.
Okay, thanks.
I've got another one here. Is there any thought to using this drug in combination with the first line treatment? I think you kind of touched on, needing at least one round of treatment. Can you maybe speak to a little more as to why that is or what the thought is behind that?
No, that's a great question. And I think that we often struggle in kind of the sarcoma clinical trial space to see, well, what's the best timing to enter these drugs? We are so grateful and lucky that we have some regimens that have, a cure rate as high as we do, but we also know it's not as high as we want. So we never, if there's we never want to risk sacrificing the cure rate we have. So usually the first step is to establish that there's some benefit in, patients when it comes back. But if we see enough benefit, and again, this is still pretty early on, we just, completed the phase 1, portion, and are in this escalation portion, or the expansion portion. If we see enough of a benefit, then certainly that might be a consideration. And maybe we'll keep learning in terms of, while there's additional preclinical studies, if it would even make more sense to do that or not. So.
And just one
Well,
more.
yeah, go ahead.
Sorry, this might be getting kind of slightly ahead of where things are at, but do you see potential for this agent to be translatable to other cancers at some point?
Excellent question. So there is there really is some good data in several different malignancies, and that's this is just part of a phase 1 study where they've taken several different types of cancers that have good preclinical data and combined them with other strategies to try to see if there's benefit. So for instance, another cohort that's still enrolling is a cohort of patients with colorectal cancer combined with chemotherapy and ozekibart. So that's another arm where there's been some benefit. So you're right, there's definitely a lot of these targeted agents or can be benefit in multiple tumor types, but you know, they're obviously you have to be smart about how you combine them and which cancer is chosen to move forward.
Awesome. Thank you so much.
I don't have any other questions on my end, Alana, unless there's any other questions. Dr. Chugh, you did a phenomenal job of presenting that. Is there anything else that you feel like is worth highlighting to the patient community that you haven't had a chance to speak on yet? I know, open-ended question.
I know, right. No, not at all. I just want to, again, thank you guys for having me speak to y'all today, and want to thank you all who are listening for asking questions, kind of motivating us and challenging us to keep looking for advancements in the care of Ewing's patients.
Okay, awesome. We'll bring this session to a close then if there are no other questions. Dr. Chugh, thank you so much for being here with us and for everything that you do with this clinical trial. And really, you did a great job of highlighting like the AYA and the adult population that still get Ewing sarcomas, because we often get inquiries, even though we're a little warrior, we still think about the big warriors as well. So thank you for bringing that to our attention. Thank you, INBRX, for bringing this trial to us. Thank you to my fabulous co-host, Alana, your first time. Job well done for helping me moderate conversation. And lastly, thank you to the viewers for joining us here as well. Please remember to stay up to date for our future Ewing's U episodes. The easiest way to do that is to subscribe to our Ewing's U emails. You can go to littlewarrior.org, go to the Ewing's U tab and find information there. You can follow us on social media, Instagram, Facebook, as we always post about our next speaker that way as well. Speaking of our next speaker, we're going to take 2 weeks off, but on Tuesday, May 6th at noon Eastern, we're going to go across the pond to Dr. Bernadette Brennan to discuss a new trial in the UK called Ewing 1. So if you're interested in that, May 6th, noon Eastern with Dr. Bernadette Brennan. So please join us for that one. That's it for now, everybody. Thank you for being with us. Swords up.
Swords up.